I think this is the Aortic Innovations session. Is that correct? I'm Paul Mahoney. This is Alan Zajarias. He's my co-moderator. I'll turn it over to Alan.
Morning, everybody. We're hopeful that today's session actually is going to be just as exciting as yesterday's. And I think the way this is set up is we'll have a case presentation followed by some discussion between everybody in the room and the panelists, just to make this very interactive and fruitful. So in the interest of time, why don't we start with having Nicolas Amoroso come and present a complex case of aortic regurgitation management.
Morning, everybody. So my case is a little bit different today, here to this conference. This is a case of, call it mixed iatrogenic and aortic regurgitation. These are my disclosures. So this is a case of a 60-year-old gentleman, hypertension, diabetes, former smoker, AFib, and he had prior severe mitral regurgitation. He underwent a mitral valve replacement with the Mosaic 29. He had a maze, and this was done at outside hospital, so the details of his course are not fully clear, but somewhere along the way in the following couple weeks, he had bradycardia, difficulty managing his sick sinus syndrome, and had a dual chamber pacemaker implanted. Over the following couple months, he had multiple admissions at various hospitals, was seen to have severe aortic regurgitation and acute systolic heart failure, class 4 symptoms. At this point, he had seen his surgeon on a couple occasions who had done his mitral valve replacement, but was deferred for any other surgical management. He showed up to our institution. He was deconditioned and not feeling great. So this is what we saw. He had, as mentioned, severe aortic regurgitation. You can see that there's some restriction to his leaflets, a little bit of thickening here at the commissures. Things don't move quite right. We got a CT in considering his transcatheter therapies, and we noticed that the atrial lead got suspiciously close to the non-coronary cusp. Sure enough, we did a pacemaker interrogation, and the atrial lead was not really capturing. And so it was determined that the lead was in fact puncturing, if not into an aortic leaflet, but very nearby, not where it belonged. I don't know if anybody else has encountered this post-implant complication.
Hey, Nick, what did the valve look like, the aortic valve before surgery?
That is an excellent question. I don't know. The report from the surgeon was that there was mild aortic insufficiency and then the intraoperative TEE report just said that there was no more MR. And that was those were the only details we were given.
How about the leaflet thickening? That valve looks dark.
Yeah, agreed. I assume that much of the leaflet thickening was there because even pacemaker lead aside, that valve is not normal. And in fact, after we took the lead out, it still looked bad. So this is how it looked after a pacemaker lead revision and the aortic regurgitation had persisted. So I agree with you. There was some degree of pathology before the operation as well.
And quick question, what was the interval timing between the first surgery and this? I'm just trying to figure out why he was surgical before and now not.
Yeah, he had spent the last 4 months effectively in the hospital other than a collective 2 weeks at home or in rehab.
And do you know if they had the technique for mitral valve replacement? Was there anything special about how they placed the valve? You know, there's very close interaction between the anterior leaflet and the aortic valve, and sometimes if you oversize the mitral prosthetic, or if you tilt the mitral prosthetic, that changes the angle of the aortic leaflets and then causes the regurgitation.
Yeah, that was our suspicion as well. We were surprised that this might not have been recognized intraoperatively under surveillance since echo was done, during the case, during the surgery. But even with this being recognized thereafter, 3 surgeons had turned him down to go back to the OR.
Are you at this time blaming the pacemaker lead for something?
I did think that perhaps the pacemaker lead was exacerbating the aortic regurgitation. It would have been a rationale why they were in the operating room, did their surgery, did the TEE. The aortic insufficiency was presumably still mild as it was billed preoperatively, and they didn't feel the need to, revise things from the surgery since the pacer was implanted later. And then his heart failure course got acutely worse subsequently.
Omar, what do you think about that? Can you miss that in the OR?
So the OR is tough, and I think you can miss it. I mean, the main thing you would see is probably the anatomy. But in the OR, of course, there are different conditions and being on bypass and everything else. So I think it is pretty easy to miss, honestly. And the TE is done in the OR, and most hospitals are by anesthesia. And there's a variable number of clips which are taken.
One thing, though, is this guy is 60, and he should have thrived after fixing the mitral. And so I would have been suspicious of why he's not improving and in the hospital for a long time. So someone should have maybe investigated this.
Yeah, in reviewing his various outside hospital notes and care everywhere, his course was complicated by flu, pneumonia, and heart failure on 3 different admissions.
Yeah, I'm a little suspicious that there may be some subacute endocarditis, because that leaflet in the CT and on the TE looks very retracted and failing to coapt and abnormal. I'm not sure that's ever going to not have severe AI with the way that leaflet looks.
Well, can you injure the aortic valve during the mitral valve surgery? I mean, definitely something could have happened during the case. That seems like the logical thing.
Yeah, and I think the point about things getting misshapen or, tugged a certain way could perhaps result in some additional pathology here.
I think I agree with, I forget who said it, I think it was Paul. So usually when the aortic leaflets get thickened and calcified, in pretty much every study, it's the non-coronary leaflet. Here it's the right coronary leaflet that's much thicker. And on the CT, it didn't look like calcification. It looked thickened and fibrotic. So that I'm also suspicious that there was some other process that had occurred previously.
It's got to go, no matter what it was.
We can't leave it like this. So, as mentioned, he had been turned down by multiple surgeons already, given his significant deconditioning. The patient himself, was also extraordinarily resistant to the idea of going back to the operating room, given his recent experience. And we considered him for compassionate use of Univalve TAVR. For those who are less familiar, Univalve is a self-expanding TAVR device and has been shown to be safe for treating aortic regurgitation without significant calcium, as shown in the Align-AR trial. An important consideration are the locators. So that would be these little kind of bar stool looking tabs here that when they drop down to engage the coronary cusp, they're going to be on the outside of the leaflets. The remainder of the valve, when it expands, then is inside the LVOT. So kind of the leaflets get sandwiched between the locators and the rest of the valve. However, even though these locators are pretty atraumatic and they're covered, by this fabric here, we do know that in people who have any perforations, healed endocarditis, perhaps a pacemaker lead that went through the aortic valve, or similar pathology, that we need to consider where those locators are going, because they are crucial to the stability of the implant. So again, just showing how we look at the locators when we're using this valve. We do a RAO to LAO sweep and vice versa, confirming that the 3 locators are in fact the front one or in the middle is in anterior and not posterior. Then we approach the annulus. Here, we're using selective cusp injections to confirm that we have capture. So you want to make sure the locator is on the outside of the leaflets, not sitting in the LVOT, because that would not provide the intended stability. Again, we had a lot of consideration of avoiding puncturing this locator through the what we believe to be existing hole that the atrial lead had created, as well as any leaflet pathology or perforations there may have been. So while there is less maneuvering for depth manipulation with this valve than, for example, an evolute valve that you might use for aortic stenosis, these locators kind of provide their own depth control. And I was particularly cognizant of this because a recent case just before this one, I had managed to spend a lot of time looking at this locator. And you can see in the panel on the left that the locator is below the nadir of the left coronary cusp. Typically, what that would mean to us is I haven't captured the leaflet, I'm not on the outside of it, but I'm in fact in the LVOT, which is not what we want. But after looking at this multiple times, it became evident to us on echo that that seemed improbable. And in fact, what it was is just a locator had gone through a leaflet perforation that had existed. This was a patient with healed endocarditis. One of the techniques I used at the time to help convince myself of this was just took a coronary wire and watched it kind of go around the silhouette of the left coronary cusp and through the same hole where the locator was existing. So it was a nice little fluoro-guided assistant in confirming that I had captured the leaflet, we just had a hole at the base of that cusp. Echo, while many people have strayed away from using TEE during these cases, just in the interest of being less invasive for the patient or less anesthesia, it can still be very important and helpful. And here we can see in the short axis view on the right that the locators, those little dots on the outside, the periphery of the central valve, do appear to be outside of the commissures, meaning that they've captured the leaflet in what seems to be all three cusps. So again, additional information to confirm we have appropriately placed these locators. And this is important because missing one cusp or perforating through one may give you still a stable implant, but if you've missed two, either they're in the LVOT or you've perforated both, we see that there is issues with the valve canting or less stable positioning. So we managed to navigate this, deploy our valve, and on the right-hand panel, you can see that there is no more aortic regurgitation. The patient felt significantly better and was discharged home. So key learnings, the Univalve Trilogy device can be successfully used for degenerative aortic regurgitation. Iatrogenic or other degenerative perforations of the aortic valve, for example, with healed endocarditis, require attention when positioning the valve locators. Multiple leaflet perforations are a risk for malpositioning, and locators in perforations can obscure your fluoro assessment of leaflet capture. Echo or additional adjunct catheter techniques can help confirm.
Hey, Nick, that was a great case. What was the problem? What was the problem? Was it the surgery? Was it infection? Was it the pacemaker lead? What at the end of the day, I know you solved it, but I still not.
How did he get aortic regurgitation? I think it's like how many licks to get to the center of a Tootsie Roll Pop? Not entirely positive, only because we've never been able to review his preoperative imaging. I have a strong suspicion that his AR was similarly bad preoperatively and maybe underdiagnosed, which is a common problem for aortic regurgitation as a whole. However, it may be that a little bit of this, a little bit of misshaping from his surgery, plus a little bit of injury from his pacemaker amounted to severe AR.
Nick, that was fantastic. Thank you so much for sharing that.
Thank you.
Our next speaker, ultimate aortic case number 2, malposition management, will be Bruce Rutkin. from Northwell.
All right. Thanks, everyone, for having me. Thanks for the course directors, of course, for the panel. We're going to dial down in terms of complexity, technical anomalies, and weirdness. So I kind of renamed this not quite ultimate aortic. It's really nothing. It's not a tour de force of malposition management. I think this is the third year in a row I've been given this topic, and we've shown cases in previous years of embolizations and snares and dragging valves across the arch with balloons into the descending aorta. But this is a case we did a couple weeks ago, and it's just something I think might be relevant in terms of some of the current things we're currently seeing in terms of patients that we're treating. This is not advancing. Not consistently, at least. Okay, so this is a 60-year-old patient, moderate aortic stenosis, class 2 symptoms, and we enrolled this patient in a moderate AS trial. Typical risk factors, as you can see here. In the interest of time, here's just the pertinent details without all of the imaging. Typical moderate aortic stenosis, meeting criteria for inclusion, 1.2, 0.33, peak and mean of 43 and 23, 3.3 meters per second, and no other significant valvular disease, sinus rhythm with a right bundle, so we all know how that could potentially come into play. Previous PCI prior to being referred to us for the trial. At that time, it was done at an outside institution, and I don't think they had knowledge that the patient had moderate AS and probably wouldn't have affected their decision-making at that point anyway, and CT was suitable for transfemoral access. Here you can see your dimensions, so 22.9. So just on sizing for a 26 for a self-expanding platform, you can see your sinuses 29, 31, and about 31 there, so looks good. LVOT is a little bit smaller. This is your typical calcification pattern for a patient with moderate AS. And here was our plan. So based on your sizing, you can see 26, 14% oversizing. Looks pretty reasonable. So the clinical challenge or the question I would ask in retrospect is for your patients that you're treating with moderate AS, in this case with a self-expanding prosthesis, do you go by the same sizing parameters and optimal implant techniques as for the same patient with severe AS? And for us, typically, we have. Our plan for this case was a 26 FX plus, percutaneous transfemoral, typical sheath and wire, no predil, obviously, based on the calcification burden, and controlled pacing is our typical. So just a couple of images of our initial implants. And again, nothing unusual here, starting in your usual location. We do some controlled pacing at 120, usually right when it starts to flower. I'm in spot 1, which is my typical spot that I like to be because I feel like we have the best ability to control the depth of the implant there. Although this may not look like an experienced operator in spot 1, you can see the valve is doing a lot of different things. It's up, it's down, I'm pushing, I'm pulling, trying to kind of nail our spot, and you can see we kind of wound up way too deep.
Well, the moderate AS part makes this really fascinating, right? Because it's part of the clinical trial, but everything gets magnified because of lifetime management, because of everything else.
So I think what we're learning as we, when we looked into this, this is great, indication expansion, moderate AS, these patients, are not happy, they're symptomatic. But of course, once you start doing these cases, you start learning some different things about, what the potential implications. So here you can see our second shot. So this time we tried to start a little bit higher to avoid the dive. It's interesting that it dove and the LVOT was actually smaller, so it wasn't like a big wide open LVOT, and you can see when we tried to start higher, we had the opposite situation, so we wound up with a pop. So now we're going to do some pacing maybe at 140, I think, in this run. This is our third attempt. Again, starting a bit higher. Looking pretty reasonable. I know this is like slow and painful to watch, but...
I'm sorry, what does the LVOT do relative to the annulus?
Smaller.
How much smaller?
20.9, I think it was. But it was not like a big LVOT. So, and then a second after that, a third attempt, when we thought we were pretty good, actually, we felt we were higher. And now look, we wound up even deeper. This was just hanging out for a second, hands on the device, with control. We didn't let go of anything, and here we are. So we're clearly having issues with our location. So at this point, we opted to remove the valve, and we upsized to a 29, even though it was somewhat out of the IFU sizing parameters. We were obviously upper 26. And the oversizing with the 29 was, I think, around 27%, up from the 14%.
Did you try to
So do you think the greater radial strength is going to make it easier to implant or harder to implant? I guess we're going to find out, but.
Well, clearly what we were doing wasn't working out. So, I mean, I thought this was really, at that point, the best option.
When you were implanting, sorry to interrupt, were you pacing at 120? Were you pacing faster? Did it make a difference?
It didn't make a difference. The reality is our usual pacing is 120 for self-expanding. I went to 140. You know, I didn't think doing 160, 180 was really going to make a huge difference, but we didn't go any higher than 140. But my sense was this wasn't a pacing issue. This was just, we just weren't grabbing onto enough calcium. Maybe we didn't have enough oversizing.
Hey, Bruce,
Did you?
Paul was bothering me when you showed this, but how much calcium was actually on the leaflets in the annulus on the CT? Do you have a calcium score? Yeah,
The calcium score, to be honest, if I remember, it was between like 500 and 800.
I was going to guess low.
Is my recollection.
So can I say something?
I was going to go back and show you the calcium burden in that one shot.
So
Yeah.
Before upsizing, why did you didn't try to go with the balloon inflation to see exactly how is the balloon, etc., making an angio to be sure about the sizing? Because upsizing 29 in SSL is a good thing because you might have a pinwheeling of the leaflets if it's too much oversized.
So you're saying, why don't we do a balloon inflation to
Yeah.
size the annulus?
No, also to free the leg. See also the stability of the balloon to go with the pacing and to check twice the situation before upsizing with the valve. This is not practice.
To be honest, that didn't cross my mind. We never were much in the way of doing balloon sizing, even back in the early Sapien days. For us, it's just going off of the CT. And in this case, what I was comfortable with was the fact that even with 27% oversizing, that based on the CT, at least we knew, sorry, I'll just get back to where we were.
If it weren't a clinical
we knew
trial.
that we knew we had sinuses that were large enough to accommodate, so.
This is such a fascinating case. And when we put these evolutes in, we're part of Progress and ProCap, so we're using the Sapien. So it's so interesting to see this side of the thing, of this trial, of this.
Yeah, I was going to
patient
ask if this
population.
were in the trial, would you have considered switching platforms?
I think if we didn't come up with a successful resolution, we would have considered switching. I mean, at
Sure,
the end of
look.
the day, trial or no trial, we're going to do whatever we need to do that's best for the patient and get
All right,
them
we'll stop
treated. But
interrupting.
I thought this case was going to be a total dud. I'm like, I didn't think there was going to be any
this is great.
discussion here.
So,
I'm like flying in
so-
last night. I'm like, oh my god, I can't believe I'm showing a freaking self-expanding, malposition.
think-
That's this, but.
So I think there's good calcium there for moderate AS, regardless of the calcium score. That distribution is pretty good. The problem now, did you see how much aortic regurgitation you had after 3 unsuccessful deployments with the 26 Evolute? Did you notice a lot of AI? Because now you might be fighting an uphill battle. Because essentially you're doing 3 balloon dilatations or BAVs, if you will.
There was no AI at baseline. We didn't look. We only look. We have echo in the room, but we just basically do our pre-scan. They're on their standby as needed if we have any issues, which I didn't consider this a major issue. And then they basically scan at 80% and then after deployment. So I couldn't tell you if there was more AI. My sense is that this was not an AI issue. I really think it was just that 14% oversizing may not be enough when you're dealing with a diminished calcium burden in a patient with moderate AS. But so here was our next attempt, 29. Started in our typical location and paced at 120. Still a little bit of movement, but you can see we kind of were able to, I think, lock in a little bit earlier here, which mitigated some of that further movement that we had previously. We're a bit in our curve. Kind of high on the non, looks a little bit deeper on the left. Swing over to LAO. A little bit asymmetric in appearance there in terms of our depth, but overall, that's looking quite good. And here's our final result, which I would say looks Looks quite good. Transthoracic, post-op day 1, discharge, mean of 5, 2.8, no PVL. The patient did have the preoperative right bundle. She was doing some intermittent complete heart block, and ultimately we had EP come and put in a pacer. So maybe another thing to think about when we're treating younger patients, potentially with moderate stenosis who have a right bundle, the implications of pacing. So some key learnings for us: sizing parameters and implant techniques may need to be adjusted for patients with moderate AS. Maybe there's some room for debate if that's to be the same thing for balloon expandable versus self-expandable, but I don't have experience with balloon expandable in this patient population. More oversizing may be needed for self-expanding, so maybe something we can talk to the engineers about. And I would just say, if you're on the borderline between two sizes in these patients, consider sizing up if the anatomy allows. In this case, we were fortunate that the sinuses were generous, and we were able to do so.
I think this is a great case because it shows again that these valves were designed for severe AS, right? When we get into moderate, I would say this case, calcium-wise, is more consistent with a mixed case with predominant AR from the calcification standpoint. And we know from the observational studies that the divide is really, with complications, is between dedicated and non-dedicated devices rather than self-expanding versus balloon expanding. And we did AS cases in the early days of Vienna valve in Europe, and the dedicated devices worked well for both, so it's kind of an in-between area. I mean, you may end up using the AR devices just because of the stability with the leaflet capture.
Yeah, this is a great case. And one thing that makes me nervous, and I've had this even with severe AS where I've had to upsize the valve with the Evolute, is now you're fighting aortic insufficiency. I think, I know you didn't point that out, but when you upsize, now you're essentially doing an AI case. That's how I view it, because there wasn't enough leaflet calcium to grip the valve, and you've done 3 quote-unquote balloon valvuloplasties. And so now you have aortic insufficiency, and it makes it even tougher. So that's a great, in my opinion, a great save. The other comment was about pinwheeling, because you're oversizing as your valve fully expanded. This is not the topic of this conversation, moderate AS, but this is one of the things that excites me most about moderate aortic stenosis, is finally we're going to have a fully expanded valve because of the little calcium that's there, right? And so are these going to be more durable? So you have a great valve in there that's really utilizing a nice size sinus of Valsalva, so it's probably fully expanded without any leaflet calcium there, and it's probably going to be very durable and have great performance. But these are questions that need to be answered.
I think also, though, to your comments, I think pinwheeling may be specific to a more balloon expanding platform. So I don't think pinwheeling is something that we're accustomed to seeing with a supraannular prosthesis. So I think what we also might learn in these moderate patients is that the considerations in terms of sizing, implant technique, depth, et cetera, may also be somewhat unique to the platform that you're using. So your experience in progress, you might have some learnings that might be different than what we come out of from Expand. So I think it'll be interesting to kind of see where it all lands.
All right, that was an ultimate aortic case. And there's
Thank
one
you.
more comment?
You go first.
I'll say
So,
one thing.
couple-
From a progress standpoint, our problem is if we don't pace, because you're talking about device embolization, right? From a progress standpoint, our biggest challenge is making sure that we're capturing one PVC and we're screwed, And so we actually aim lower. We aim 70-30, all right? Because you have very little wiggle room. PVC, boom, now you're 90-10. Absolutely, we have.
We weren't told to modify our implant technique, or at least the sponsors didn't say we think you should do this differently. But as you're doing these cases, you made that adjustment on your own.
Yeah, and so hearing these unique perspectives are going to be critical, if and when this becomes an approved therapy for moderate symptomatic AS.
So another comment I want to make about this case is that on average the gradient was 20, if I'm not wrong. How was the gradient before treatment of this valve? How was the gradient, transvalvular gradient?
It was, if I remember correctly, it
20.
was 43 and 23 was the peak and mean.
23.
Mean
So it's-
23, yeah.
The mean is 23.
Yeah.
So it means that with this valve the final gradient was 10.
It was 5. Final mean was
15
5.
millimeter of mercury.
With an EOA of
difference.
2.8, but yeah.
But with this patient as a valve, that we don't know if it is commissural aligned, probably yes, but the risk of sinus sequestration, in this case, if we go for intervention, is extremely high. So the point is that when we treat these patients, just to reduce of 10 millimeter, 15 millimeter of mercury or gradients, we have to think about the lifetime strategy. So this is my major concern about all this stuff.
Yeah, particularly in
We will
the
see.
low-risk young population. Good job. Next, we'll have Paul Mahoney, our co-moderator, to talk about facilitating successful TAVR and TAVR.
It's a good segue because as we watch these moderate cases with these large valves being put in a nice high implant, they're going to come back, and we're going to have to deal with them. So I picked a case, a TAV and TAV special considerations addressing risk of coronary obstruction, because this has gone from a theoretical esoteric concern to kind of a day-to-day concern, and we're seeing these patients every week in our practice. So I got an 89-year-old male with Zajarias post-TAVR, had a 26 sapien in 2015, so got a good run out of it. Hypertension, has leadless pacemaker, hypertension, came in decompensated to heart failure with both mixed AS and AI. DVI was 0.24 and severe AI. They were calling it a paravalvular leak. I was a little skeptical of that 10 years later. Mild to moderate MR and moderate to severe TR. So the CT scan, as you can see, the area is 460, a little bit underexpanded. Left coronary height was 14.5. The right coronary height was 18.8. The left, as you can see, is clearly within the frame of the sapien. The right looks like it comes off maybe just above the frame, so that was helpful. The VTC on the left was 3.2. The VTSTJ was 3.3. The VTC on the right was 4.1. And the VTSTJ was 3.7. So Steve, who insisted on having a microphone for this talk, do you think we need to do anything about this, or are we okay to put a valve in?
You have to modify this
Okay.
this valve because you're obstructing both the left and the right.
Agree. Mostly. And when
Only I say the right is because your STJ distance is kind of tiny also. So
the STJ is kind of tiny, although we felt that the coronary was coming off above the frame. I don't know if I showed that well enough on the CT here. And we felt, but the left main was clearly at risk. Another important thing when you're looking at a sapien, because the post distribution is random, you really want to make sure you don't have a post in front of the left main, which is going to significantly impact your ability to modify the leaflet. But here we felt the left main was coming off where that big red arrow is, and nicely bracketed by the sapien posts. So
another point to consider is that when you measure VTC in this case, is that in all cases you have to go with pre-dilatation. You cannot treat, a sapien valve going with a TAVR in TAVR without pre-dilate the first sapien. Otherwise, it's very difficult. On the bench tests, we demonstrated a couple of years ago to further expand the valve. So the real VCT is the one that you need to forecast after the post-dilatation. In this case, maybe, I don't know if this valve is 23, you have to go at least with a 23, no matter the regurgitation at the end. But for sure, it's mandatory to pre-dilate.
So, great comment. I will say, in an 89-year-old gentleman with AS and AI and a VTC of 3.2, even though we're going to modify the leaflet, my enthusiasm level to expand that sapien anymore was quite low. And so in this, while I agree with your comments in general, from this patient specific, what is our goal for this 89-year-old? Do we want a 12, 15-year result? Probably not. Do we want to get out of the room with the intact patient? We do.
Is the valve canted in any way away from one of those coronaries?
It was a pretty tight fit. I don't know if you could appreciate that on the CT scan. It seemed to be fairly coaxial. If anything, maybe tilted a little bit towards the left. But that's a good point, because very often these are not coaxial with the long axis, and you have to kind of pick and choose. And this one, I think, it was a relatively small sinus, and everything was kind of taken up. We felt the right was coming off at 18.8 above the sapien frame. So our plan was to modify the left, and we'll talk about that. So,
Paul, how far above the frame was the right? I couldn't tell
it was
that.
18.8 from. So when we measured the height, that's from the bottom of the frame, was 18.8. The top of the sapien frame at 26 is about 18. Okay, and that's the lower part of the right coronary. So we felt we could perfuse that coronary in this 89-year-old. It would not have been wrong, I think, to modify that leaflet as well, although I don't have the perfect picture, but we felt that it was safely coming off the top. So as long as we did not put anything above that, we would perfuse that coronary.
Well, do you change your depth of implant depending on what you saw on the CT scan?
Yes, although just remember the tube graft is going to be from the sapien leaflets, not from whatever you put inside of it. So an Evolut is 13, a Navitor is 11. So usually the problem is the leaflets of the first valve, not the leaflets of the second valve. With the Evolut, sometimes we'll go a little bit lower though to bring the coronary plane down.
And then I just, sorry, I
That's
just
okay.
will
I felt bad
caution
turning
on
my
the
back on the others.
pre-dilatation aspect of this with that sapien valve. I know it's done in bench testing, but there's a lot that we still don't know about endothelialization. And so that could be a catastrophic event. I mean, sure, you could have intravalvular AI, but you could certainly have annular perforation.
Actually, at TCT this year, we're going to present as a late-breaking trial 150 cases of THV and THV. I can guarantee to you that without pre-dilatation, the final grading is too high.
Foreshadowing. Okay, let's see what happens. The good news about being the presenter, you know what the next slides are going to show, right? So that's why I'm calm up here. So we use standard equipment. We planned a left balloon-assisted basilica and valve. So, you know, again, with TAV and TAV, it's not quite the same as TAV and SAV. How you modify the leaflet, you've got a circular steel cage, a cylinder. And so if you make a linear cut and then just jam it up against a cylinder, you're going to end up with not a whole lot of increased room. And I have a really well made out visual aid for that coming up. So balloon assisted allows you to splay that a little bit more. I worry about devices like Shortcut for TAV and TAV because you're going to get a single linear cut, and without an ability to display it, you may not get the look you want. And Unicorn, although I'm not a huge proponent of Unicorn, may make sense in some of these cases because you will actually make room in front of the leaflet. But basilica is
Paul, which one's better? Unicorn, balloon-assisted basilica, or Shortcut?
I think Shortcut for TAV and TAV is problematic. I wouldn't do it. One, because of cost, and two, because you have no way to splay that leaflet. So I think you need to, making a linear cut and then smashing it up against a cylindrical frame doesn't give you enough access. So I think balloon-assisted basilica or some Unicorn variant, there's about 40 of them now, makes the most sense to me. But there's probably other opinions up here, which I'd love to hear. Or not. Okay, thank you.
It
All right.
shows.
We didn't really talk about Navitors. That's off-label, by the way. And currently in the Vision trial, we're doing a TAV and TAV registry for Navitor, and I encourage you to put your patients into that. But we like Navitor. I liked it. It's self-expanding, so better hemodynamics. I did not plan to balloon this valve, the Sapien. All your comments aside, in the 89-year-old guy at risk for coronary occlusion, I was going to put the valve in and then check what our gradients were, and then post-dilate as needed was my plan. It is a large cell designed for coronary access, a lower coronary risk plane than other self-expanding, and it's the cheapest valve in the market. So I kind of like it for valve, and so we planned on using that. I don't know if there's any comments from the panel on that valve choice. Would anybody have done something differently? I think Evolut would have worked. I think Sapien would have worked.
This is the Navitor or the Vision?
Vision, yeah.
This is the Vision one. So the only thing with this valve is to be sure to go for commissure alignment with the second valve, because if you do the basilica, but you don't have the commissure alignment, you stay at the same point you started.
Absolutely, yeah. The worst case is you go ahead and you do your balloon-assisted basilica, and then you put a post right in front of the left main. So you got to make sure you get the commissural alignment. With Navitor, you can avoid commissural misalignment by looking at it pre-release. You can't really control it, but you can certainly screen for it and then recapture and redeploy the valve if you think you're at risk.
The other thing on these is that after you do your leaflet modification, you're looking at the skirt quote, right, the skirt height. But if you notice at the commissural post, the skirt is higher, right? There's fabric that goes up the commissural post. So if you also put that misaligned in front of the coronary, you've essentially just erased what you've done.
And so the way to avoid that is you use your lean on your basilica. So your basilica cutting view where you're bracketing the two posts in front of the left main, it's usually an iliocranial view. Before you release the Navitor, you go to that view, and as long as you don't have one dot on the right side of your screen in front of the left main and two dots on the other side, you're okay. You want to make sure you have some rotation on that. So again, you can't really control it going in, but you can certainly control it before you release it to ensure that you don't have commissural misalignment.
So, Paul, the radial strength also of Navitor is lower than the other balloon, the other valves that are on the market. So, if you did not have a high gradient, would you still plan on post-dilating? Or would you be concerned that the gradient was high to begin with? constraining the valve inside a previous metallic stent?
We had an opportunistic plan. We're going to look and see what result we have and then base it on that.
You know, all those points are good about pre-dilating and looking at the radial strength, because if you look at that valve right there, the original valve, even though it lasted a long time, it's not fully expanded.
Yep.
You could see pretty clearly how it's impacted, especially on the left sinus.
Right, so you see that big ball of calcium on the left sinus, right where the AL3 is?
Yeah.
You know what's right on the other side of that big ball of calcium? The left main.
Left
So
main.
he got 10 years out of this one.
Yeah.
All your points are really good, but I was really worried that if we did an aggressive dilatation in this gentleman, that we were at high risk of coronary obstruction, which would have been unsalvageable. So in this case, even despite that, we got a little bit nervous about it. And
I would just make the case that no matter which valve you choose, whether it was a sapien or an evolute or a navitor, all of your concerns are identical.
that's fair.
Can I ask a quick question for someone like this who's 89? What is the surgery role in this? Do they all go for salvage if something goes wrong, or what is that discussion prior to attempting something like this?
That's a great question, because in terms of resource utilization, in terms of how we're going to approach that, so in our lab, we have a bailout discussion, and the bailout mostly centers on a sternotomy, because going on ECMO to fix a coronary obstruction is something we would probably offer everybody, because we can do that in the cath lab under control, but we don't have a sternal saw, we don't have a surgical prep. This 89-year-old guy wasn't the picture of health, so there was no sternotomy option for him, but we would and have put people on peripheral bypass to fix a coronary obstruction in the short term. But they probably are, but that has to be a very limited goal. So that's the focus of our discussion on surgery. Is this a sternotomy candidate or not?
We can't use the word bailout anymore at our institution, but we call it a conversion candidate or not.
Okay, fair enough. So, yeah, I mean, you know, we would do simple things. We would go on peripheral bypass, but we're certainly not going to take a sternal saw and try to go through the chest. So here we have traversing the left coronary. You can ignore that balloon there. That's a little out of order. But you see we're through. You can see the wire moving nicely with the leaflet. We've got it snared in the LV, sort of standard technique. It's important when you do basilica. There's a couple of key tips, whether you're doing basilica or unicorn. When you traverse the leaflet, use TE, and I use TE still on 100% of them, because there's a couple of key things. One, it can show you your position. Two, it can help troubleshoot your basilica system, make sure you have bubbles. And then three, you want to make sure that your wire is not going through the leaflet, through the anterior leaflet of the mitral valve, and then back into the LV. All right? And that can happen, that does happen. It's entirely preventable, and TE can, in about 2 seconds, show you the answer. And you would see it, I don't know if I have a pointer here, you would see the wire coming through here, coming around here. We saw a recent case of a unicorn with a wire. The Safari followed that track. It looked like it was in the LV apex. They blew the balloon up. They got their unicorn, and they also got a big hole in the mitral valve. So just be aware of that, because that's preventable. And this is just saying the same thing I just said. You can use your TE to make sure your wire is correctly positioned. You can make sure that you're in the LVOT, not taking a little vacation through the left atrium, and you can proceed. You can also, when you pull up, make sure you haven't wrapped it around any subvalvular structures, because you'd start to see some significant MR at that point. So as you cinch it up and you get ready, you can just do a quick assessment. So especially if you're new to the basilica world, I think TE is very important. So we did our balloon-assisted basilica. And again, the idea here is we got that cylindrical metal cage. We want to splay this as much as we can. Here's my on the plane last night illustration. Without balloon assist, you get a nice linear cut. With balloon assist, it splays more. I think this is the argument against shortcut in this setting, because I don't know how to splay with shortcut. Does anybody have any experience with that device here? Okay. You can use TE to confirm your split. You can see that there's a new, pretty severe jet of AI. The short axis can be very helpful. Unfortunately, we didn't capture that image. And then we placed our Navitor and Sapien. Again, didn't pre-dilate. We just deployed the valve. Again, I think all your points are very valid. This is a patient-specific approach, and we were fully prepared to post-dilate this if we needed to. But our final result was excellent, and our gradients were single-digit, and the patient did well, was discharged home the next day. So just this is going to become, I think, for most TAVR operators, this is moving very quickly from a theoretical to a practical concern. I just wanted to show kind of a typical case and how we dealt with it.
It's a great case. Did you recannulate the coronaries?
We did a root shot and shot it was open.
So you didn't recannulate the
Did
cornea?
not.
Yeah, that's just yes or no.
Can I make a couple of
Felt that it was unnecessary at the time, Dr. Yakubov, thank you.
a couple of considerations related to the second valve selection. So when your first concern is the coronary, and you decide to go with the intraannular valve, that is Navitor, it's pretty much the same of going with Sapien. So if you want to, because the patient is 90 years old, so if you don't want to do this, complex things, you have to be congratulated about the basilica and so forth. But the other way around is to put the Sapien into the Sapien and it be lower, because you don't need to smash completely the leaflets. It's enough to displace the leaflets, and the gradient is going to be very low, and you don't need to do anything else. But if the problem is the gradients, actually probably it's preferable to go with the supraannular valve, supracoronary valve, and not intraannular valve. Related to the coronary, we need to make a difference between the coronary perfusion and coronary cannulation. Because actually, coronary perfusion, we can visualize the coronary artery. It doesn't mean that we can cannulate it. So this is the reason why in the registry that was mentioned before, in all cases, we went with invasive evaluation. That is much more important than echo. And the second one is selective cannulation to coronary artery, because this matters when you treat a 65 or 70 years old patient.
So I have a question for Steve. If you attempted to cannulate and you couldn't cannulate, how would you manage this patient differently?
I would have done exactly what you did. I would have been grateful to get out of the case, showed that the coronaries are patent. But if the patient was significantly younger, I probably would have tried to cannulate the artery. And if I struggled, then I would go backwards, go with, diagnostic catheters, figure out how to get there, and then modify the pathway so that somebody doesn't call me someday and say, you know what, you blocked my total entrance, you're the problem. But I would have done exactly what you did in that case. The only other question I had for you was, though, you showed that you're drawing about 40% more splay. Is that proven data?
That's Jaffer published at 37%. He did bench testing only, where he did balloon-assisted versus regular
Just bench
basilica inside
testing.
TAVR, just bench testing, and he showed that. So
Yeah.
that's Jaffer's data.
And that's why I just asked you, which one really is better? What's the best thing that we should be doing? Because we're doing all of it, but we don't really know.
I think it's going to come down to they're collecting registry data on Unicorn. Unicorn has some theoretical advantages, a little bit easier to do. We have a 250 patient registry on Basilica, which gives us a lot of safety and efficacy data. I think we're waiting for that for Unicorn and which version of Unicorn. So this is still kind of a data-free zone. I will say you're exactly right. If you recannulate, let's say the patient was 70 and we were worried about that. Now you're recannulating and you're modifying the pathway orthogonally in a straight line rather than trying to go behind a stent frame, which I think is always helpful for further operators and people trying to get back in the coronary.
I think if you really have a younger patient or somebody that's going to last longer, I'd protect the coronary before putting the valve in afterwards, and then kind of work your way backwards if it's that important.
All right.
Well, this was a great case, and it clearly illustrates that we have a lot of different options, and depending on the patient that we're dealing, we can try to modify them how we do it, either with basilica, balloon-assisted basilica, balloon expandable or self-expanding valve. So thank you very much for helping to illustrate those items.
This will be entertaining.
Yeah, sure. This is a trap.
I know.
I 100%. I think right now we're doing the best we can with what we have. I think we await dedicated devices so we can do expansion. We can safely do this. We're right at the beginning of identifying these problems, but I don't think we'll be doing anything that looks like this in about 3 years. I think this is kind of proof of principle, but that's a great point. And I'm going to get off after that because Dr.
Thank you,
Schwartz is.
Quick question. How are your patients tolerating acute AI?
They tolerate it really well. I mean, the basilica is kind of uneventful. We don't, we just lacerate it. Usually, every once in a while, someone get a little bit sick, but usually they tolerate it very well. Yeah.
Great job.
Great job. Jonathan, why don't you come over and talk about balloon dilatation, fracturing, and TAVR challenge, please?
It's always a tough act to follow, Paul, but that was especially tough. That said, you set me up well. All of your talking points, we'll just pause them because you might see some of this come up in this case here. So, all right, so officially this is supposed to be a talk on balloon dilation, fracturing, and TAVR challenge. There is a little twist in it, so we'll get to that. There we go, okay. So this is an 83-year-old woman, severe AS, prior bioprosthetic TAVR with a 21 millimeter Magni-Ease in 2012, so got a pretty good run out of that as well. Multiple other comorbidities. I guess the only notable one maybe is the right bundle there. Trying to have moderate to severe bioprosthetic AS with a gradient of 26, but an area of 0.9. Very minimal activity was leading to symptoms. She still was pretty active and was really desperate for relief. And referred to us for some aortic valve interventions, high risk for re-op, STS of 9%. So just to confirm the AS here, you can see the gradients and pretty restricted leaflet motion. So we got a CTA, showed just mild obstructive coronary disease, so we didn't pursue a cath. The 21 millimeter Magni-Ease with stent diameters on the CT measurements were 19 by 18 or so, area of 265. And the left coronary leaflet in particular had diffuse calcified thickening. There was no rocking or restricted motion of the valve itself. The area was about 0.8, and the coronary heights, about 10 for the left main and 11 for the right. The VTC on the left was 5, and on the right was 8. Femoral access looked fine. Don't have the actual CT, unfortunately. This is just it didn't look quite this bad, but kind of close to what we had here.
Hey, Jonathan, did you have any doubts that the valve was really the problem? I think you had a mean gradient of 26 in one leaflet that was calcified. Were you ever in doubt that the symptoms were due to the valve not working?
A little, but I think the CT, what we thought was pretty convincing. She didn't really have any other obvious causes. I mean, I guess you could say maybe older diastolic heart failure, but with the area and how it looked on the CT, we weren't worried about that. But reasonable question for sure. Patients that we are unsure about, we'll take to the cath lab and just use dual catheter measurements of the valve gradient. So access looked okay, no problems at all there. So just for the summary here, now this is an 83-year-old woman, failed small prosthesis in a very symptomatic patient. She's high risk for re-op, low, moderate coronary heights. The risk was felt to be intermediate for left main obstruction with an increased risk of coronary obstruction. If we do the valve-in-valve TAVR, is there maybe some concern about patient prosthesis mismatch? If you do pursue TAVR here, are you worried about balloon valve fracture or remodeling? Would you do it pre versus post? What's your threshold to do it? Panel, what do you think about this?
So why don't we just talk with everybody over here? But we normally do post-fracture. We don't do pre-fracture. How about you, Paul?
We do post-fracture. I think the data is shown to get better gradients, and we will check. And again, there is a risk associated with fracture. So if we have single-digit gradients, we won't fracture. So we do it post.
I don't know what to do. We've done them both ways, and I think it just depends upon the risk of the patient at the moment or what the ability to fracture that valve. I think that valve's a little harder to fracture, right? The Magni-Ease. I can't remember. I always have to look it up. 24. Yeah. So.
Yeah. It takes a bit, but it is fracture.
How much was the gradient here?
Sorry?
The gradient.
It was 26.
Small gradients. So the only fact that I prefer to go with pre-dilatation first again is because sometimes it might be very difficult to cross the valve. But with this gradient, it's not too difficult. So you can do whatever you want. You can fracture at the end, but some kind of pre-dilatation sometimes is useful. For instance, with mitral flow, other valves, sometimes it's not possible to cross the valve.
What size was this again? 19?
21.
21.
Does the fact that the coronaries are a little close change your idea on pre versus post fracture? I think in general, we all tend to post fracture. The data is pretty good that shows the gradients are lower if you do it post, but does that change if you're worried about coronaries?
Can we see again the CT scan?
Maybe.
It's a pretty small valve. He might have left the OR with a 15 or 20 millimeter gradient.
Yeah.
Yeah. This I would err on the side of fracturing just because you're never going to get a gradient low enough.
But it
without
also looks like this might be as good as the surgery could do. I mean, this looks like the surgeon used all the room he had available to him during this
It's
case.
a small patient. Yeah.
But this isn't the actual CT.
This isn't, it's close to what ours
is
look
not the
like.
patient.
This is the same, this is a Magnese.
This is a representative.
Yeah, the VT STJ wasn't quite as bad in our patient as it is in this one.
If you predilate, the risk is aortic regurgitation, is hemodynamic decay, or let's say some minor stroke or things like that, but there is no risk of coronary occlusion with this valve. The risk of coronary occlusion is that when you go with the THV valve involved, at that point you have a risk of coronary. Might have a risk of coronary occlusion, but not with predilatation.
Sure. Yes.
So his question was, how do you people factor in the VTCs pre-fracture? That's a great question for you.
Yeah, I think fracturing introduces a wild card element. You just don't know where it's going to fracture, how it's going to fracture, how it's going to move. In all the basilica I've done, the only coronary obstruction I've seen is when I fractured the valve post-basilica. Now, you're going back in orthogonally. It's easier to go back in the left main than if you hadn't done it. But there is, you're moving things around, and it's hard to predict where that valve is going to fracture and how the calcium is going to move when it does. Well, with the 26 gradient, though, in a 21 valve, I mean, it's going to be very hard to get that to single digits without it. And ask why they didn't do a root enlargement with the first operation, yeah.
Yeah. Maybe I'm a wimp, but I think balloon fracture after. I mean, that's what I always do anyways, if I'm going to. Plus, is there great mortality data on balloon fracturing? I know you get a nice number and we feel better leaving the operating room, but what's the data? I haven't seen anything tremendous in terms of long-term morbidity mortality on balloon fracturing. And there's certainly increased risks that we've seen. So I'd like to see better data before taking on that risk. And if I'm going to balloon fracture, I like to do it after because I'd like to also do less harm.
Yep. Mm-hmm.
So why do pre-fracturing?
Yeah.
Has anybody done leaflet modification and then fractured?
You're foreshadowing here.
Leaflet modification.
This is great.
Yes.
Have you seen my slides already? I don't know. Paul, your question about VTC. So we don't have data on that, but if you ask Adnan, he says it's about an average of 4 millimeter expansion when you fracture. So to factor that into the VTC. 4. Yes. For sure. Yep. 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 And that's why we were worried in this case. So even though the VTC was 5, that you would think that's sort of intermediate risk, we thought we're worried about this. So we decided to go ahead with valve and valve TAVR with TE and fluoroscopic guidance. We were going to plan on checking the coronaries after and then use the shortcut device, which we can talk about, Paul, and you brought that up a lot in your last talk. They do recommend using Sentinel, so we did that as well. We were going to assess the splitting, make sure that things looked like we were going to be able to put a TAVR in safely, and then use a 23 millimeter sapien to go ahead with it. So here's just an example putting the Sentinel in. For the shortcut device, you are able to position it very precisely, and so this is sort of just a picture of the arm extended, and the way the device works is there's a little blade that comes up from the center shaft, which I think you can see it here. We're positioning that so you extend the knife through the leaflet. This is all very visible on TE, and then once you're in the right spot, you just basically pull takes about maybe 15 minutes or so, assuming you have good pictures. So it's maybe a little bit faster than Basilica, but maybe not for Paul. And then you can confirm the split pretty well on TE here. So we felt confident that we got the split where we wanted. We were able to proceed with the TAVR portion of things. Relatively straightforward at this point. Did not have any hemodynamic issues with the AI in the meantime, but we were...
Anyway, based on this angiography, actually the risk of coronary obstruction is 0 to me. It's 0.
It is now, but
It's not even 1%. Because actually, we need to be honest in that, because actually, when you look at VTC, you don't have to look at the VTC, but at VTA, because the VTA is the point where you create the sinus sequestration. But if you repeat the angio here, you have more than 3-4 millimeters there. So
on the T, it looks very large.
No, to be honest, actually, this is just to be real. I want to be real.
It also looks like the surgeon put in a valve that was 5 times smaller than it should have been. Look how big that root is.
So there's a potential discrepancy between this aortography and the CT. Omar, do you think that...
But the CT wasn't for
The CT was a representation.
Keep forgetting,
remember,
keep
it was
forgetting.
not
the CT shows it well.
But
It's very large.
it's a little bit of a lower implant.
Well, okay, let's just assume that's the CT. Is there ever a blooming artifact that could fool us?
So I want to give lower expectations about CT measurements. So I debate this with Jaffer, right? So the CT spatial resolution for most scanners is somewhere around 0.5, let's say on average, 0.5 millimeters. So when we debate 4 versus 5 millimeters, I think we have hubris to think that we're that accurate. If you look at 1 millimeter on a ruler, it's extremely small measurement. So I think this 4 versus 5 is kind of a false sense of security, right? Once you're in that range, then you probably have to look at the whole case. But I think 5 millimeters to me is still very small.
Just bear in mind, though, if the penalty for failure, it's the Fu Manchu principle, right? The penalty for failure is death, not your death, but the patient's. So a lot of these borderline cases where you're just not sure.
I agree. That was part of my point. So if you have 5,
yeah.
To me, that's not very different than 4, even though we say 4 is the cutoff.
And here, I think it was a little bit of a low sapien implant, which all of a sudden the left main and the sinus look okay. But if you'd put that 2 millimeters higher, it might have been a different story.
Yeah.
And it's very hard to control that precisely. So.
we purposely went a little low also.
Regarding the size of the index valve, before this era of root enlargement, 10, 20 years ago, majority of the valves placed in the U.S. were 21, 23 maybe, but this is very common to see this undersizing.
And agree. I mean, the CT, we do put a lot of stock in the CT scans, but at the end of the day, it's an unpredictable component, right? And if you would have had deployed a 0 or at 5% in the LVOT, you would have a much higher risk of obstruction. So, I mean, you played it safe, you played it right.
Yep.
Jonathan, post-dilate this or not?
Yes. Yep, right here. So after the initial deployment, we had a gradient of 14. We thought, there's always a little bit of concern with the left main being obstructed, but based on the aortogram, we didn't think that'd be a problem. So we did post-dilate, got a nice pop. Unfortunately, I didn't record the cine of it, but you can see the relative diameters here. Very good expansion. The gradient was 3 afterwards. And just because it's sort of fun, I know this is a different case, but we were able to record the actual fracture. I think this is the equivalent in the structural world of like when the CTO when you get through, but it's so satisfying when you get the pop. If you look on the bottom part there, right there it goes. Yeah. So. Okay, so then finally aortography here. Everything looked really good. Coronary's open, valve well expanded, gradient of 3. She did have some complete heart block. Had to get a pacemaker, which was a little surprising for valve and valve, but ended up doing well. Gradient was 5. Just showed a picture of the setup here, where you have your stopcock and then you add on your indiflator just so you can really increase the atmospheres when you're doing the inflations. Adnan's chart that sort of guides the fracturing, but things went well here. I think probably the main point here is just Adnan says that there's about a 4 millimeter increase in diameter when you do BVF, so take that into account when you're looking at your VTCs. But overall, things are good here. As we get into the era of more valves failing, there's about 2.5 to 3.5 incidents of coronary obstruction with a very high mortality when you do it. So very important just to think about this ahead of time, and we're probably coming to an era where we're going to need to really look at deciding about leaflet modification and blue valve fracture to get good gradients afterwards. So, and that's all. Thank you,
Okay,
guys.
Jonathan, so now should we fracture before or after?
I think you have to tailor it a little bit to each patient. I'm a fan of after. I guess I've been lucky. I have not had any valve leaflet damage when I've done it. And so far so good, but I do worry about that.
This is a great case. I don't think we place enough emphasis on the preoperative coronary angiography and aortography. I think we just check that the coronaries are okay and we get out of the cath lab when we're planning these TAV and SAV situations. I'd like to see more aortographies in different views to really highlight, kind of this concept of die, don't lie. And I really appreciate Omar's being humble about the CT, because we do have some discrepancies. And yes, you should err on the side of caution because it is the patient's life. But, everything we do carries risk, and these cases are super complex. And if we can avoid doing these adjunctive treatment, these risk mitigation therapies, it'd be nice. And so it'd be nice to spend a little bit more time in the cath lab and just kind of go back to the basics and do some good aortography.
Agreed.
Especially for TAV and TAV.
Yep.
I have a question for Sarah, if you don't mind. So from a surgical standpoint, what have we learned and how have you changed your surgical techniques based on all of this reintervention? Because we're doing all kinds of hand flips and back flips to overcome some limitations. How has your root enlargement strategies changed? Just talk a little bit about that.
So, historically, we were able to upsize by 1, maybe 2 sizes with the Nix and the Manugian techniques. Recently, the Y enlargement has become very popular, which really splays open the left non-commissure, and you can upsize by 3 or 4. I think the index placement of the surgical valve, it's nice because you can align the commissures perfectly, but the way you get in trouble is the size of the index valve. It's not the orientation, really. Sometimes with a very aggressive root enlargement, you can have a cant or a tilt of the valve that also has its own set of problems that come with that. But generally, it's been pretty successful.
Last comment related to the final gradients, because we think just it's the ring fracture. But we have to admit that when we do the post-dilatation, actually we post-dilate for 3, 4, 5 seconds maximum. We know with the balloon in the coronary, it takes 15 seconds to get the right pressure at the level of the coronary. So it means that many times you have to try, before thinking if it is risky at the cracking of the ring, to go with a double inflation, that is double tap. That means you go 5 seconds, then you wait a little bit to do another inflation for 5 to 6 seconds, and the gradient will decrease significantly. So you don't have to think straight ahead to the cracking of the ring.
I do think with the fracking, the balloon inflations are a bit longer. Maybe not quite 15 seconds, but they are a little bit longer.
Feels like
It does. It feels really long. I know I'm out of time. Last thing I'll mention, Dr. Yakubov, you were asking about the best way to modify leaflets. Again, I don't know if there's a best answer. I do like Joffer's data on, it's sort of interesting, the electrocautery cuts versus the mechanical cuts. There is a difference, and that's sort of interesting. The one point that is nice for shortcut is you can tailor a little bit better about where you're putting your cuts, as opposed to basilica, where you can kind of, tell where you're going through with your wire, but not always.
French size is different.
Yep. Great, thanks.
Great job. Thank you very much. All right, TAVR versus surgery. All right, we'll hear from our surgical colleagues. Dr. Palmer.
Yeah, no, thank you for the invitation. I've been here a few times now, and each year is more complicated, and so I just really have a lot of respect for my structural colleagues. But the title was versus surgery, but I changed it because it's not really a competition. It's more of, it's nice to have both options on the table and know when is surgery the right choice. Where do I point this thing? Oh. Okay, so this was a nice case from last year. This woman, 77, anti-cardiolipin antibody syndrome, unfortunately had a lot of thrombotic complications from that. She had bilateral BKAs, she had peripheral vascular disease, diabetes. She had severe AS and understandably got a TAVR in 2021. 3 years later, she presented to another hospital with dyspnea and chest pain. And this TAVR was also done at another hospital. So her TTE showed that the peak velocity was 4.6, and she had a mean gradient of 52, preserved LV function. Another thing on the initial CT that made her a little high risk was her aorta was also very calcified. It's not a porcelain aorta, but it's a significant amount that might make you pause to not want to cross-clamp this aorta either. So she was turned down for surgery as well as for valve-in-valve at the other institution and transferred to Minneapolis for further care. Our CT assessment for feasibility of valve-in-valve, the VTC on the left was 4.7, and the takeoff is just below the stent frame there. On the right, it was 2-ish, and the right coronary takeoff is very close to the annulus, well below the top of that stent frame. And so my question, and it kind of was already answered, but what is too close? What is your absolute cutoff where you would not even attempt a valve-in-valve? Is there a cutoff?
For me, it's about 2 millimeters, but there is another double check that they used to do during the procedure. That means go with the catheter in and to make a little angio to understand in the right projection what is really the room before, between the struts and the coronary, if it is feasible to go in and out. So this is something important. If I decide to go with Simney or with a snorkel, etc., this is something that I used to do. But 2 millimeters is the cutoff.
The higher up from the insertion point, the more willing I am to take a very small VT. We've done VTCs down to 0.1. But if it's high up enough and you get enough splay, you can open up to the metal cage. I think you can do it. So there's another factor in like how above the annulus you are.
Yeah.
What about this one? Because the STJ also looks sealed on this one.
Oh, this is a
On the
terrible
right side.
case, but yeah, I mean, they don't have a lot of choice. I think I would attempt it.
Okay.
Another thing is to evaluate if there is a commissure alignment or not, because this matters a lot. Because if the commissure is in front of the coronary, this discussion has less value.
Okay. So the clinical challenge, first of all, is this feasible? We already talked about the short VTC. I think the takeoff being very low is more concerning to your point. But just if it's feasible, that's one question, but also, is it durable? This woman already had early degeneration of her index TAVR, and we can't assume that the TAV and TAV durability would be longer than that. She was 77, but she was still, very active. She had her prosthetic legs and good quality of life, and so her life expectancy could have been 10 years. We had to plan for that. So the choice really was between an intermediate risk surgery versus a high or even prohibitive risk valve-in-valve. So we talked about this at length at our valve conference, and luckily or unluckily for me, the decision was for surgery. So
we would be delighted if the surgeons agreed to do this case. We are not fighting you for these cases.
We're excited. Our default is usually yes. This lady gave me, I worried a little bit, but we said yes. So we scheduled her. She was in-house. Unfortunately, she arrested the day before her surgery. She was having bowel movement, became unresponsive, VFib-RS, PEA, multiple rounds of CPR, getting her from the bathroom to the bed, prolonged intubation, don't know her neurostatus. She's in the ICU. She's very sick. Her lactate is very high. She's on a lot of drips, and she is circling, and her LV is now very sad. So what are the options now? Well, I was going to say now they're both prohibitive risk. Well,
No, but why you say that? Because at 30 days, the mortality of TAVR explantation is more than 10%, 12%. So how can we say intermediate risk? The risk is very high always with TAVR explantation.
you're saying
So
the,
this is the point.
why wouldn't
So
it?
actually, I think the first choice is to be safe for the patient. The first choice is TAVR in SAVR. In case it is considered in somehow contraindicated, we move for TAVR explantation. If we have a reason to think about endocarditis or thrombosis or something different or pure structural valve degeneration, we have to go to surgery. Otherwise, TAVR in SAVR is the option.
No, I think she was intermediate risk prior because, she had good LV function and her only concern was maybe mobility afterward, because you can't really use your upper extremities at all after surgery. But I thought we could get her off the table, and a TAVR explant in this setting wasn't technically that difficult. But okay.
Is the STS going to come up with TAVR explant score, do you think? Or is it already in there to create?
No. So there's no score. We just came out with a multi-procedural score that is, the triple valve and plus other procedures, but there's no consideration for TAVR explant. These are the things that are not captured by the calculator, and in fact, taking her, it counts as an index AVR in the STS view, and so this actually affects the AVR numbers. So we had to make a quick decision, and so one concern is, do we do anything? Should we do palliative? And then, we also considered an emergent BAV. Paul, I don't know if you remember this lady, but this was you. So you took her, yes, you did, very quickly. And we decided to do this kind of as a bridge to decision or a bridge to, because I don't know, it went well. So her mean gradient went from 52 to 27. She did have a little stroke, and she was
Sarah?
still very sick in the ICU.
Sarah, can I interrupt you for
Yeah.
a minute? So he takes the patient, looks to me, I know you originally said that they may have 10 years to live. I think they have like 20 minutes to live. And
Well-
he takes them for emergent BAV,
Mhm.
which means that if he tears the valve, you have to operate right away, kind of, unless he's going to go totally obstruct the coronaries. What was the plan there?
Yeah, so this was not a BAV as bridge to, it is a bridge to decision, and this was kind of an emergent thing. The family was there, they're not ready, they want everything done, and so I thought it was reasonable to try, and it actually, she did well because she did make a neurologic recovery. She had no permanent deficit. She recovered her renal function. She was back on telemetry. Her mean gradient was still 25, and so now we're back where we started. So then we took her to surgery. And so this is after I opened the aorta, you can see her TAVR valve. Now at noon is where where the RCA, you should see the orifice of the RCA. And the leaflets themselves are very calcified, but you also see this pannus at the periphery, this kind of smooth ingrowth of tissue. So she had a couple of reasons why I think she failed early. To take these out, this is not like a straightforward AVR. You have to be a little bit patient, and this is peeling the stent frame away from the native leaflets. She's on lifelong Coumadin for her, yeah. And so, yeah,
Hey, Sarah,
yeah.
Sarah, what did the balloon do to the valve?
We don't know why she arrested, honestly. We don't know why she arrested. We could only assume it might have been from that. I don't know. Yeah.
Actually better than you expect. That's a pretty good result. Yeah, yeah, strong work.
What do you remember? What size balloon was used?
Oh,
And then how do you size that?
I don't know. It wasn't in the notes, so.
Yeah, a BAV and a prosthetic valve is always a little bit of a gamble. You get leaflet fracture, wide open AI. Usually you have to have an immediate TAVR backup strategy. This patient didn't really have one, so this was kind of a Hail Mary. Yeah. This one you should remember, it sounds like. Well, this looks like an invasive procedure, so
Yeah.
why don't we
Well, can I
keep
show
going?
it coming out? Okay, so then, you know, this is edited, but it takes a while to take this thing out. And then you'll see now you can see the orifice of the RCA. I mean, you'll see it later, but we then have to kind of inspect and see what kind of damage was left behind. This is taking out the left leaflet. The other two have already been resected, and there's the right coronary that now you can see, and it's really close to the annulus. Then we proceed with sizing the valve. And now we put in the replica side, and so we can really orient those commissures and have a very nice, well-seated valve. I think we did a 23 in Spurs for her. So her post-op echo looked good. Her mean gradient was 10. She was discharged to rehab, and then I did see her a few months ago, and she's back to her normal kind of baseline life and functionality. So this was a very lucky case. But a lot of opportunities for learning. So for complex TAVR, I think technical feasibility is the first consideration, but not the only one. And so even if it is possible, and in her, I don't think it might have been possible, but even if it was, for lifetime management, we had to kind of tailor it to the unique situation that she was in. Intermediate risk surgery may be the better option if you feel like the TAVR risk is too high. Or if there's concerns for longevity. And then for these complex patients, you know, we always say a thoughtful discussion, comprehensive heart team, but I mean, that really is the case at our institution at least. And so it wasn't just the initial decision-making, but even throughout her care and her course and the procedures that she had, I think that collaboration is how we were able to get her through this.
That was awesome. You know, one thing that we have to tell you is that, first of all, for you to take the patient to the operating room is a heroic feat. And I think many surgeons would not have even done that. So kudos to you for doing that and getting that. And
So I would say it might have been brave or stupid, but it was my second year out from training, but I trained with Dr. Fukuhara at Michigan, who did a lot of TAVR explants, and so I really was lucky to have that exposure and experience with that, so I felt comfortable taking this.
I think we've been originally jaded by the first registry data of TAVR explant that have very high mortality, but I believe that the newer publications actually have shown that the risk of mortality is much, much lower, and that technique has been much, I don't know, simplified or much more honed in, which then allows for the improved outcomes. And
I think that the mortality, a lot of it was the patient population as well, because it wasn't just the anatomic considerations of taking out the TAVR. It also, they needed their mitral, there were concomitant things done. There was, I mean, they were a sicker group. And so from a technical aspect itself, we have made it safer. And now we know things to look out for. You know, don't rip out the anterior leaflet of the mitral valve, you know, be patient. So there are things that have made this not high risk, intermediate.
Yeah, there's still an important role for our surgical colleagues. There is such a thing as a high-risk TAVR, lower-risk surgery, and I think we sort of lose sight of that every once in a while. This is a great case to show that, so thank you very much for sharing. The pictures are phenomenal, so thank you for bringing those. yeah, we have time. Go ahead. We're going to run a little late. The break after, so it should be all right.
Well, hey everybody, my name is Mark Gajjor. I'm a local structural cardiologist at UT here around the corner. Sorry about it being so cold in the rooms. We like you to heat stroke outside as quickly as possible, so that's what we do with the temperature here. I'm going to talk to you guys about how high is too high for your transcatheter heart valve, and I like to think about this as our version of annular enlargement, right? Kind of optimize the index AVR. And so these are my disclosures. So why do we aim high, right? Why do we aim more aortic with our THV? So we know that there's lower pacemaker risk by using the sinus, right? Putting the valve in the sinus, maybe the valve is more expanded. It can perform better hemodynamics, therefore potentially better durability, right? These are question marks. We got a lot to learn in this space. Disadvantages of being more aortic: if you miss the annulus, you could have paravalvular leak, device embolization. And most relevant for this talk, in my opinion, is the need for coronary access can be diminished. Not diminished, but it goes up if you're doing younger, lower risk patients, and it can be more difficult to access those coronary arteries. And then for TAV and TAV, you really complicate the TAV and TAV picture, as these guys have illustrated, if your index THV gets in the way. So high implantation, we have data, right? You have less pacemaker implantation risk if you have a supraannular THV, if you implant it more aortic. Coronary access can be difficult with the THV skirt, particularly with the supraannular valve. But regardless of your type of THV, you sequester the sinus, and as a result, TAV and TAV becomes extremely difficult. But is higher actually better, right? We have to think about risk versus benefit, right? Is there significant benefit in aiming high? Well, the figure to the left comes from the Partner 2 registry, where about 13% of those patients got permanent pacemakers, but there was no significant long-term disadvantage to having a permanent pacemaker. And maybe that's because only about 50% of those patients actually use their permanent pacemaker at 1 year post-implantation. So is the reward actually there? I don't know. But we do worry about the risk. I mean, we've been talking about it this entire session, right? As we're doing younger, healthier, lower risk patients, the likelihood of needing to access their coronary arteries is going to increase for whatever reason, acute coronary syndrome, et cetera. And as these patients outlive their THV, we have to start talking about TAV and TAV options in lifetime management. So the risk is higher and there's questionable reward. So let me get into a quick case here. 85-year-old female, we did a TAVR on her 5 years before for aortic stenosis. Now she's coming back in with NYHA class 3 heart failure symptoms. And she's got severe aortic stenosis with her THV, so we launch a TAV and TAV workup. To do a TAV and TAV, and I don't think we talked about this, but you have to go back to the initial imaging and implantation, right? So this is her initial CTA, 3 Mencio. For a 23 millimeter nominal prep sapien, she's 5% oversized relative to annulus, 3% relative to the LVOT. Her coronary heights are quote unquote fine, 13 and 13. Her sinus of Valsalva is a bit narrow. It's 26 millimeters. But here, we decided to aim high, right? She's an octogenarian. Let's give her one good valve that's fully expanded. It'll last the rest of her life. We're going to high five. And we did. We landed about 95.5. We avoided a permanent pacemaker, excellent hemodynamics, and we were really happy. We said one valve for the rest of her life, no permanent pacemaker. Well, now we got to go back to the future and start thinking about her TAV and TAV option. So we reached out to our good friends at DASI and we said, can you predict the risk of coronary obstruction? I'm glad we didn't talk about DASI yet. And so they're using computational modeling, et cetera, et cetera. I'm interested to hear your thoughts, Omar. You know, what is the risk of left coronary obstruction with both an intraannular and supraannular valve? And it's less than 0.7, which is considered high risk. And so that's a problem for TAV and TAV in her. And so they come up with these really pretty images and movies to show coronary obstruction with the intraannular and now the supraannular THV, TAV and TAV, and you can see that the left coronary obstruction risk is real. So I don't have an exciting case to show you with TAV and TAV and TAV and adjunctive therapy because she decided not to undergo higher risk TAV and TAV with these risk mitigation features and chimney stenting, et cetera. So medical management was pursued and she passed away a year later without any therapy and on conservative therapy. On the flip side, we have a similar situation where, very similar, we had a younger patient and basically said, screw it, let's eat the pacemaker implantation risk. Let's take it on. Let's land this 70-30, and we did exactly that. She got a permanent pacemaker, was not dependent on it, and this TAVR valve failed, this THV failed, and so we had to entertain TAV and TAV for this second patient. Sent it off to our friends at DASI again. The risk of coronary obstruction was reasonable. We elected to go with a self-expanding valve. Once again, the movies are nice, they're pretty, and they help us out. And so we put a supraannular self-expanding valve within the sapien valve here. We still protected the left coronary because it's new, we're nervous, everything went fine, and she did fantastic, excellent hemodynamics. This is a nice algorithm that comes from a paper in 2023 that kind of characterizes, where you should implant it and who. I won't get into the nitty gritty of this, but I'll just summarize it by saying, how high is too high is kind of an interesting question. I think it should just be, hey, every case, where are we going to implant this valve? It shouldn't be dichotomous. Is this a good TAVR candidate or not? Should we, what valve are we putting in? It should also be implantation depth. We have to get the first valve correct, even if they're 80 years old, 90 years old, because you don't know, these patients might live. As we know, TAVR is moving the needle, making patients live a lot longer. And so you should always consider the next valve and maybe not be so afraid of the risk of pacemaker. And then, of course, as we're doing lower risk, healthier patients who are younger and going to live another 40 years, et cetera, we have to be really cognizant about making our choices correctly up front. And of course, all of this is irrelevant because of leaflet modification, right? Ideally, we land them high, we do leaflet modification for the TAV and TAV, and we just keep on doing that over and over again and not worry about these things. Thank you.
All right, great job going through that. So the pacemaker, the only thing I'd say, I think the risk of the pacemaker is dependent on the age of the patient. The partner data showing no difference was within 5 years. And I think the risk of RV pacing, thank God an electrophysiologist here, but the risk of RV pacing starts to appear after 5 years. So in a 65-year-old, it might matter a lot more than a 90-year-old.
I have a question. I agree. So some of the indexes that were shown there were based on one paper of not such a big data set.
I think another important point with the question is when high is too high. One of the answers is it depends on the width of ascending aorta. If the width of ascending aorta is large enough, you can go high because you don't have ever and ever a risk of coronary obstruction in case of redo intervention. The point is that the SMART-like patients is a problem because we look at the gradients and the difference between core valve and sapien is 7 millimeter of mercury on average, but nobody take care about the fact that there is 1 year follow-up, and in case of reintervention, with a tall frame valve, you need to go for TAVR explantation because the risk of coronary occlusion is extremely high. And why is that? Because the ascending aorta is very narrow. So the answer is not to look at the pacemaker rate, but the width of ascending aorta. In case of very large ascending aorta, you can go also tall in tall frame because you can cannulate from outside. So the most important predictors is the ascending aorta.
All right. Any other comments before we wrap it up? I want to thank our panel. This was a great discussion. I want to thank all the people who presented and all those people who commented on the presenters. Thank you very much, and I appreciate you guys coming for the talks. There you go.
Pleasure.